This all teed up, and especially thanks to everyone for signing in to today's event. I'm just going to jump right into kind of some background and what we do and reasons we do it, and then get into a little more detail as we go through about where are we utilizing this, what space is that in, what success we're having with it, what have we derived from it, and what have we changed from it. In short, to start, why would we need this, right? So biliary obstructions, just as Shirley alluded to on the introduction there, it's not a new technology in the realm of RFA, but it is newer in the use of a percutaneous route, especially for a transhepatic route, which is what we typically will see this in our realm. But basically, we're talking about anything that is going to compromise the biliary tree, whether that be focal, non-focal, multifocal, failed previous procedures, whether that's ERCP or surgery, anything that's going to block that transit of villus content. There we go. Sorry about that. So what causes obstruction? So there's benign and malignant are big, probably heavy hitters in interventional, right? So benign processes being whether they're something we created in the medical realm, inflammatory diseases, stones, infection, all those kind of listed. Malignant processes are a little different, and I bring these up and give them as examples because I think the way they're treated, the way they're handled, and the way that application may be used for RFA are all different. So whether it's a primary tumor or multifocal metastases, even extrinsic compression in the malignant realm, probably going to be treated a little bit different than extrinsic compression in the benign process as well. So what does this manifest for us, both whether it's patient presentation or imaging? Oftentimes patient presentation, I don't know how many of the clinicians on right now or that are going to listen run a clinic, but that's where I primarily see patients is either through the inpatient referral systems or through the clinics that we have provided for these patients. But any typical cholangitic feature, whether it's jaundice, itching, fever, chills, weight loss, all the things that we know and expect. But also imaging. So what all have they had done? Getting that kind of medical background from the patient, if you will. Whether that's ERCP, which we have shown in the middle of the screen there, as well as MRCPs showing obstructions with the ever so reliant arrow sign there. So being able to put all this together, this puzzle of patient presentation, what's going on, the imaging, and how do we fix it is all key to really, getting things started in the process for a benign biliary or malignant biliary stricture protocol. So that segues right into what are the traditional processes. ERCP with stenting, we just showed a picture of an ERCP. That's a pretty well-known previous and actually current, gold standard in certain scenarios with stenting or without stenting. Surgery, certainly on the table. Where we live, at least as I speak for the interventional radiology community, for the most part, being PTCs or percutaneous transhepatic cholangiography with drain placement. And so, there are obviously always other constituents and things like that, but what does that boil down to for us? That boils down, at least in my practices, or in practice I'm familiar with, benign biliary stricture protocols. I think they're very pertinent. I think that they help patients out in situations where they're not a candidate for any of the aforementioned. And I think every program and every institution and everybody's going to kind of have their own spin on it, their own tailored technique, if you will. And that's kind of what we did here as well. So it's going to vary highly from institution, as I mentioned. Our first stab at this, if you will, was back in 2018 when we published a benign biliary stricture protocol that we had success with to reduce the risk for surgical intervention and revisions. But again, that's years and years old now. Modifications have occurred within our own institution. I'm sure that a lot of the physicians, practitioners, whomever is on or listening have also ran into that. So just for example, in our original benign biliary stricture protocol, we did the upsizing of drains, but along with that, we also used cutting balloons. We had attempted angioplasty balloons at one point, prolonged the largest drain placement. It's really been tailored over time, as long as we can get our best results. So this was a good jumping off point for at least our institution and our practice of, hey, how do we want to get something formal out there, present it to our community as a way to treat patients and hopefully do so effectively. So the big issue, and I know I'm speaking to the masses with this. The most common complaint from patients, by far none with at least in our practice, is the duration. So the one benign stricture protocol that we initiated, the one that we kind of tailored and changed, is very long, very arduous. It can take nearly a year of just simply placing a drain, upsizing over time, whether or not you use balloons or whatever technique you wish to kind of expand or open that stricture. All of them take time, at least in our experiences. And with longevity comes issues, as we all know. Pericatheter leakage, cholangitis, issues with capping, issues with the bag, issues with it getting caught somewhere. They always add you're going to add sedation in most cases if they're revisions or reaccess. And some patients are, ASA4 classes and they need anesthesia. There's a whole different mixed bag of reasons to see these patients on a routine basis, and also in the emergent one where they come into the ER because of any of those aforementioned things. It's a big strain on the hospital. It's a big strain on your practice, not only for scheduling purposes, but all the things that we discussed as far as supply, sedation, and those types of things. And I think we all can agree that we can't take supply for granted anymore. So those are a lot of the issues that we run into with benign stricture protocol, specifically the ones that we had in place, and some things that we really want to try to tailor and minimize. So that's when biliary RFA comes into play, at least how we got into the space, if you will, for benign strictures. So ablating primary lesions with bipolar energy, this is all on the StarMed side. I don't want to dive into all the fun technical detail. They're going to be far better at that than I am. But essentially, as Shirley alluded to earlier, temperature sensing system to manage ablation zones. It's been applied for thyroid. We're all pretty aware of that. They do a great job of marketing that and demonstrating it. Prevention of overapplication via the generator and the impedance, and then the variable lengths. So the variable lengths play in more way than one. Not only the length of the ablation site, but the length of the catheter that is used, and we'll dive into that in a little bit. But as you can see, the ideal ablation temperatures there listed in the top right. This is where we want to see those beyond reversible into that cell death area, so we can get a good scar in the long run. This is again the dedicated generator, which was pictured earlier, and we're going to have another representation of that momentarily. But this is kind of a brief, just very high level bird's eye view of the ELRA device and its approach to using it in the biliary world. Here's a good picture that was published before. This is before RFA and post RFA. This was taken from StarMed as well. As you can see, just the ablation of that narrowing is going to give that a good scar, if you will. So the whole idea behind this is to aggravate that tissue, cause inflammation, and allow it to scar around something. So essentially creating a new conduit that will hopefully be long-term and make sure that new conduit is, at least maximized by catheters that we inherently use before anyway. So brief overview of ablation. For us, this is an over-the-wire removal of an indwelling drain. We place a sheath, anywhere from 8 to 10 French, depending on patient and anatomy. We typically only use cholangiography. We do not use cholangioscopy, but we are working with other institutions to isolate their findings as well, and hopefully get a good comparison between the two etiologies for identifying the narrowing. place the electrode over the wire at the place of narrowing, and then typically a 2-minute burn. Temperature and wattage can vary. I've rarely had to change that, in only one instance, in fact, but usually 80 and 8, respectively, regarding those two. We'll go into the exact protocol that we have in place, but this is just an overview of what a standard ablation looks like. I specifically I did not want to say this is the only way to ablate, because every physician will have their own approach. IR is an art form in my mind, and I stand by that. So everybody will have their own way to do these. This is what I've found in my experiences. This is a brief video showing the entirety of that 2-minute process. So as you can see, between what are radiopaque markers there on the catheter, this is the smaller of the aforementioned. So this is the 11 millimeter, I believe. But as you can see, that wattage, the temperature is going to vary greatly in order to get your general averages for the impedance. So as you can see, as we go through time, we're getting the response we want. It's a very focal ovoid response for the actual stricture ablation. And then we're also getting everything we need clinically along with this. So as you can see here, the wattage temperature varies, the impedance tries to stay consistent, and our time continues. So that just allows us longevity with the process in order to get to that 2-minute marker. I will say this is a little sidebar for something I'm sure that we'll be discussing later as far as how we do things. I was initially using anesthesia on these inherently, just in order to make sure that they were tolerated well. And then I have now moved away from that large part to go with moderate sedation. At our institution, moderate sedation typically includes fentanyl and Versed at varying doses to keep the patient as comfortable as possible. I will use lidocaine at the entry site. That's just out of A, habit, and B, out of the manipulations between the drain, the wire, the catheter, etc. And we'll get into a little more specifics on the types that we use for this procedure. But this is, again, the general overview of what 2 minutes looks like, and you can see the focal area of treatment, specifically with this 11 millimeter device. And as you can see here, we're coming to an end at 2 minutes, and the impedance and everything staying pretty consistent. That is that. So how do we do this? Obviously, one of the most common questions, at least I've gotten throughout this process of, okay, that's great, this all sounds good, but how exactly do we do it? This is what we've conjured up for our new benign biliary stricture protocol, which we have implemented across our group and have had a lot of success with, and we'll get into that in moments too. But ideally, we undergo the initial cholangiography with an internal external drain placement. Typically, I would say the vast majority, we start pretty slow and steady. So an 8 French biliary drainage catheter is typically what we use. Instead of the longevity of, okay, now we're going to upsize it over every 2 to 3 weeks, add all that time, and then keep the 18 French in for the longest duration, whether that be 6 months, 9 months, whatever that may be. We've rapidly expedited that. So 1 week after placement, we'll use the Elver device and introduce it over the wire system to the biliary tree. We'll then use the device across the lengths of the stricture and then immediately put an 18 French biliary drain in. We typically do not hospitalize any patients for this. As I mentioned earlier, I have largely converted to moderate sedation versus anesthesia. 4 weeks later, the drain will be externalized, and then we do a capping trial with an externalized drain. So just a multi-purpose drain, whatever you guys use, just to see if that's going to work, for the most part being a placeholder. In more specifics, not to bore you with old detail, but these used to be on very long working systems. So I was having to use exchange length, Amplats 035 wires, whatever you're going to use, That has now been shortened greatly due to the fact that we have a 40 cm working device now. So I'm down to those 140 length wires. I typically always go over an Amplatz wire or whatever 035 system that you use as a more robust system that you feel comfortable exchanging over. Once you're able to get the sheath in place and get the device in place, you can always check via contrast where your device is in respect to the anastomosis. And I'll get into some of those pictures momentarily. But other programs that I know of for sure are using cholangioscopy, which is fantastic to directly visualize it as well. So what does this mean? Obviously, the big thing is we've dwindled down a 1-year process to a couple months. And it goes right hand in hand and play with all the other things we discussed. We have a lot less radiation. We have a lot less sedation, anesthesia, hospitalizations, strain on the systems, strain on your practice, whatever that may be. So at this point, all we've done is modify something we had already had universally in place to really expedite it and help the patient out. That is it, bar none, is help the patient out, get this done quicker with less strain on all the things we discussed. But really the thing is, okay, that's great. Is it comparable as far as results? We're going to jump into some cases and then discuss those. I elicited 2 cases here to view because I think they both go along in the benign stricture protocol, but they also show it at 2 varying degrees of things we typically use them for. So the first one is a 40-year-old with transplant, post-surgical anastomotic stenosis. This is probably bar none the most common, at least in our practice, being a transplant center. So we can see our access here on our peripheral right duct going central, the area of narrowing. There's nothing too attractive about cholangiography, so I took out a lot of the wasted time with showing the transit just to get right to the bread and butter. So this is, again, to go back, the day of placement, your French drain and the small bowel across the stenoses. Here's the day of ablation. So to remind you, that's going to be a week later after we've kind of let this cooled off a little bit. A lot of these patients are presenting cholangitic and those types of things. So this is a day after ablation, or excuse me, a week after for the day of ablation. And as you can see, we have a wire going through the exact same system as we are transit of biliary tree as we had before. This is an 8 French vascular sheath. This is a 25 centimeter length, so it gives us a little bit more working room. And this allows us, as I said again, to monitor where we are along the biliary tree and in respect to the anastomosis throughout the duration of the procedure. Here's the day of ablation. So to reiterate that again, this is the sheath, 8 French. We've now advanced it a little bit down here to we have a better shot. I will do a magnification. I will do different obliquities. I will do everything I can to maximize my visualization of this anastomosis. As I'm sure all of you are painfully aware, we run into these issues a lot as far as a 2D space of fluoro to see where this is, just depending on how the anatomy is. So get creative, get however comfortable you need to get there. And then this is the 11 millimeter ablation device. And again, it was nice seeing that visual provided by StarMed earlier because it shows you the exact ablation zone that you would expect around this. So obviously here's the area of narrowing, just juxta to it is going to be our ablation zone and deep to it. I will say for the workhorse in our practice is certainly the 11. A majority of our benign biliary stricture protocols are due to anastomotic strictures. They are typically very focal. So this is by far the working horse for us. Here's the day of externalization. So to back up a little bit, this is the day of ablation. This device comes out after that 2-minute protocol we just went under, and then now we're placing an 18 French drain as both an internal, external drain. So once that drain is in, it will remain to bag. I don't cap these right away. Obviously, I want everything to cool off. So at this point, all we've done is really aggravate that tissue, cause that inflammatory cell death, and then get a very large bore system in immediately for that to scar around. So this would be the day of externalization and that next swing of the protocol, if you will. And we can see here we have pretty robust flow through the area of previous stricture. And this is via the exact same mechanism. So we're creatures of habit, makes things easier and less error. But we have the wire through, we have a sheath. I typically, again, use 8 French. People can use whatever they're comfortable with. I typically like a longer sheath, so I have the ability to shoot from here or the CBD or wherever I need to see a little better. And we can see that that looks very good. So this is the externalization process. This is where we're going to leave that 18 French multi-purpose drain, whatever drain you prefer or you have in your practice, to keep in the actual liver while capped to see if the patient's going to tolerate this procedure. So here it is again. This is with the drain in it, proximal to the anastomosis, terminating around here. So we want to make sure that everything's draining, even with this just access drain capped. And we can still see after contrast injection, things are transiting quite well. Case 2, similar idea, different etiology, different mechanisms. So we have chronic choledocholitis with CBD stenosis due to scarring, presumably. So no previous surgery, no transplant, nothing that required an anastomotic, if you will, stricture. So additional history of cholecystectomy at one point due to the chronic choledocholitis, multiple failed ERCPs. So they were unable to get through this, likely due to this narrowing that we obviously observed with the imaging that was required to come to this diagnosis. So they had already failed a PTC with drain. So nothing really getting across there. So this was a left approach. Same idea, 8 French. This is the earlier onset through the Krebs set showing the area of stenosis, which, just to orient you, here's our catheter, left common. There's a previous cholecystectomy. Here is our native common bile duct, as well as the transitive contrast. So focal difference here: 1, not anastomotic. 2, it's an inflammatory process that resulted in this focal process. 3, it's a little bit larger. So we were able to see that diagnostically on our initial placement with the 8 French and say, okay, this isn't our typical 11 millimeter ablation device. We're talking something a little bigger here. So this is the 18, which earlier on in my experiences, I was hesitant to use just out of, quite frankly, lack of experience with the devices beforehand. So I was kind of spot welding my way through. So with the 11, I knew how to use it. I was very comfortable with it. So I would hit it in a few sequential spots. With the 18, it just saves that time and that kind of variability that you'll have of the burn across the stenosis. So this is the actual 18 over the exact same system. So I've got the 8 French sheath in, an 035 wire, the ablation device, and I'm able to monitor that. Again, I find the obliquity I want. I use contrast, so that kind of is my guide to make sure that with breathing, with everything else that's involved, I'm not moving this device into the bowel. I obviously don't want to perf the bowel or anything like that. So that kind of gives me my visualization versus cholangioscopy, which is going to be direct. This, no need to see the same thing, but removal and drain free. This is at a 6-month follow-up when I built this PowerPoint about the past 3 or 4 weeks. So they are completely drain independent after failed pretty much everything. So again, just to rehash this, 18 in a native system due to inflammatory process. And then we have an actual anastomotic stricture with the shorter segment and altered anatomy. So key differences kind of across, I've used them in a lot of other things such as inflammatory processes, malignancies, et cetera, and with the exact same approach. So results, right? This is what we were alluding to earlier. That's great. You're able to help these patients, help your hospital systems, and a lot of the medical strains, if you will. But what is the results? Because obviously, if this doesn't work, this is all for naught. It's great. It's a great tool to keep in your back pocket. But if it's not going to have the same results, we're not going to use it, right? So we're currently enrolling patients into our specific benign biliary stricture protocol. We've done approximately 30. This was, again, a few weeks ago when I was building this. We've done a couple more. I did one last week. About 18 to 20 are entered in that, meaning the extra 10 are either A, malignant, B, they were already a failed benign biliary stricture protocol, which I will say that's the biggest eye opener for me was that statistic. So out of the few, again, it's not anything I can translate with any power to say, this is the end all be all. But out of the few that did fail our benign stricture protocol, so meaning that 18 French in for over 6 months after the gentle upsizing, they still failed that with capping. I was able to ablate and successfully have them drain free. It's kind of a reiteration of malignancy, multifocal, refractory, anything that we can need it for. Only recurrences I had is to multifocal inflammatory inherent process. So I did have one patient who had PSC. We treated a focal area. They were drain free. They developed another one in a separate area. I've had one patient who had a peripheral left duct one that required a lot of work as far as planning and processing to ablate that successfully. And they also did well and went drain free until the recurrence. So again, these are the underlying disease processes where you can imagine that just spot welding them as they show up is great, but they're in for the long haul. So a lot to be said whether or not that's going to be, the answer for them versus a long-term drain. I don't have enough data to support that, but I will say that those have been the two that are one to two. One's mine, one's a partner's that we've seen. Limited follow-up with malignancy. Out of the few that we've done, we had success of removing the drain and getting them home for palliative. Obviously, not a lot of follow-up in the ones that we've done. The malignant protocols that we have in place, if we're waiting on disease process, we will not do this procedure with them. This is kind of, for the most part, limited to benign biliary stricture protocol. That's how we geared it. There are scenarios where patients want to go home in that palliative situation and they're interested in it. We kind of put that in the hands of oncology as well as surgery and transplant, et cetera, to kind of make that a multidisciplinary agreement of how to move forward. So I don't have a lot of follow-up in the malignant realm, but our study is not geared towards that by any means. These are the references and things that we've used to build this lecture and kind of show what we're doing, some of the results we're having, and kind of go through questions. I know that that's going to be the brunt of it, and we expect that and anticipate it and have a few things lined up. But I really appreciate your time. I really appreciate StarMed putting this on and getting some awareness out there, as well as Shirley kind of hosting us through this. So I'm going to turn it over to Shirley, I believe, and she's going to help moderate some of this Q&A. Is that right, Shirley?
Yes, thank you so much, Dr. Rohr. That was wonderful. So now it's Q&A time. Some questions from registration will be shown in the slide right here. You can also use the Q&A function at the bottom of your window to submit more. The stage is back to you again, Dr. Rohr.
Thank you. Thank you. Yeah, so these are some of the questions that we thought were pretty pertinent just right out of the gate. So how does the biliary duct stent placement affect the RFA if action is required? Intra-stent stenosis with the RFA system is not well explored in my realm at all, because our hospital, for a multitude of reasons, likes to stay pretty stent free as far as what we place, in that biliary tree stenting, if you will. Now, the mobile ones that are exchanged via GI are a whole different story, but for us, the true stent that we would place is far different. We don't place a lot of them intentionally, both from our own practices and our colleagues. I will say that in the setting of indwelling biliary stents, the removable ones, exchangeable ones via GI, as I described, I do move them out of the way to ablate. I don't feel comfortable ablating those. So I'll just snare those and take them out myself, ablate, and then either put our drain in or that stent back. So I don't, I have never ablated one with an adjacent stent in it, just out of worry that temperature or anything along those lines will cause an issue. How long do you have to maintain external biliary access for? Again, this is just my experiences. So, The external biliary access, so that trial is only a few days, so 3 to 5 days, obviously depending on weekends and where people line up and how well they do. We specifically cap them in that trial, so they are capped drain that is external, where we say, all right, are you going to do okay for this next 3 to 5 days? And if you are, then we're okay to just remove those. And we typically do those in the peri-procedural area. We don't take them back for anything unless we need to. We are checking bilirubin along the way with these at every visit. So out of those 3 to 4 visits, we are checking a bilirubin to make sure that we're staying on track. The suggestions for reimbursement coverage is a great question, and one that we specifically brought up because it's going to vary, obviously, across insurance companies, which I'm sure we're all so fond of, and B, hospital priority, and as well as, hey, what are we billing for? I can't say to the exact codes off the top of my head, but I did provide those to Shirley and to StarMed if you're interested in the exact codes. But typically, as a bird's eye view, we're billing for the ablation process, so RFA, and exchange, fluoroscopy, and your cholangiography. So those are pretty standard, pretty typical. Those are the CPT codes we use. I've provided some of those to Shirley, but I don't have a specific protocol set aside for CPT codes to go through insurance companies. This is just what the hospital has been doing historically for us. So I think that covers those three pretty well. I'm going to just jump into the Q&A and see what we have. So the first one here is complications seen in patients, whether it's immediate or long-term. Okay. I'll do the first one. We'll do one by one. So the complications seen in patients, this was a very, very tenuous and arduous task for me initially, getting comfortable with the system, because in the back of my mind, everything was, am I going to compromise the anastomosis or the bowel? So I did not want this advanced into the bowel at risk of, even during peristalsis, whatever it may be, to zap that too bad, requiring surgery. Obviously, they just had a surgery. I want to stay away from that as much as possible. Typically, we do not ablate patients that are under 4 weeks out. So whether it's immediate or long-term, as far as the complications, that kind of goes hand in hand. I don't want to ablate anything that's going to compromise that anastomosis. So that goes right into complications. I don't see a whole lot of complications. Knock on wood, I have not had any. As far as what I've had in the short term, you will see some changes in numbers. So whether that's your liver function test, if you're at a university hospital or wherever, if you're an inpatient during that process, which is rare on our case, but it does happen, those labs are getting checked. So you'll see that bump. I've never had anybody have an issue that would hospitalize them. I've never had anything that would require surgery. I guess the only thing I've seen that I don't know if I'd consider complication is debris that was pushed through with the 18 while I was doing it live with cholangiography. I kind of expect that, but obviously kind of showing what we did. I think there was a couple other on there. Okay, smallest, youngest patient. Youngest patient I've done would be transplant in that probably 35. I've not done any pediatric ablation whatsoever. The short and long-term outcomes, that's a great question. That's the one I was alluding to earlier. The longest out we are right now is around 18 months as one of the first patients, and that was a failed benign biliary stricture protocol of our own. They are still drain-free. I've only had to replace them in those with recurrence at different sites for autoimmune disorders and inflammatory disorders. So I have not had to replace drains on anybody in our study currently. But obviously, we're trying to get those numbers up. I don't know about your practices, but with us, they kind of come in waves of when these surgeries are done and those who do and don't get anastomotic strictures and things like that. So it's really dependent on the referral base of that. So that's why we're trying to get those numbers up. I'd like to get about 30 or 50 patients enrolled before we really start doing some data crunching. Are you able to take the ablation zone slightly across? Yeah, so that's what I was alluding to earlier. That's where I was very hesitant early on. I would only use the 11 for that reason, to stay as juxtaposed as humanly possible on that stricture. I take extra caution into not advancing into the bowel. In my mind, I'd rather ablate the majority of it and the majority of that into the duct versus into the bowel. I can only say that just from experience. I don't have a lot of case reports of any injury to either or requiring any additional intervention because they haven't happened yet. But that is what I try to do is take that ablation zone just pretty much dead center on the stricture with either opposing side. If I have to waver, I'm going to waver towards my access instead of into the bowel. Is there evidence to support RFA and benign ureteral strictures? That has been done. I have not done it. This was just talking shop at events and different places. I might defer that question to Shirley or somebody over there if they've had case reports written up of it, but I do know it has been done.
I think that's a great question. We'll look into our database and then provide more answer to you, Dr. Hawk. Thank you.
Do you keep the same settings? Yes, I keep the same settings for every patient. I kind of alluded to it a little earlier when I was talking about the temperature and wattage for the 80 and 8. I've only had the device itself has a lot of safety control mechanisms. So if the impedance gets kind of out of whack at those settings, it should just shut down. The only time I've ever ran into anything where I manually changed something was the variance of the impedance was very high. So I shut it down immediately, unsure why that was, thinking, okay, it's me. I'm just kind of I'm wavering or they're breathing my device in and out of the spot I want it in, and that's where I'm getting that variability. So I did adjust it just by the wattage. I didn't change a whole lot. I went from 8 to 6, and then I felt that the impedance was much more consistent. I was also a little more cognizant of where that was and timing with breathing when I could, as far as going over the wire. So that's the only time I've ever altered it, and that was in one setting, but typically same setting for every patient.
I think that's all the questions we got. Any more questions from the audiences? Okay, that's great. So we can give you back about 20 minutes. Thank you so much, Dr. Rohr. That was very informative and comprehensive. We greatly appreciate your time. I also want to extend our gratitude to our audiences for joining us tonight. Your engagement have truly made this session very, very enriching. So for the doctors that have asked specifically about CPT codes, our rep will reach out to you and provide more information. And same as you, Dr. Hogg, about evidence to support RFA in benign ureteral strictures. And then for those of you seeking other information to get started or other questions to get answered, please visit our website, and then you can always submit an inquiry. Our reps will reach out to you very promptly to answer all your questions. You will also receive a brief survey at the end. We would greatly appreciate you filling it out to help us make better webinars for you down the road. Thank you once again, and we look forward to connecting with you in the future. Have a wonderful night.
Thank you all.